is meant by respiratory system? What is the main function of respiratory system? Exchange of oxygen and carbon dioxide. So the respiratory system, in cardiovascular system, we have seen how the blood is flowing within the cardiac system and what is the effect it is giving in the systemic circulation when there is a defect in the blood flow within the cardiovascular system. Okay. In the respiratory system, we are mainly going to see with the carbon dioxide and oxygen exchange. Okay. So between where and where these exchange mechanisms is going to take place. So that is what mainly we are going to study. Okay. So first we should know the anatomical structures which is involved in maintaining the physiological functions. So they are called as functional anatomy of the respiratory system. So what are the structures which is involved is the respiratory system, it starts from the nose. So from the nose, it gets and enters into the pharynx, larynx, trachea, and you have the trachea is dividing into right and the left bronchus, and inside the right and the left bronchus entering into the specific lungs. And inside the lungs, it is undergoing various divisions in the bronchus. So what kind of divisions it is taking place? We will see it one by one. And before going into the mechanism, how the respiration is taking place, the respiratory tract, we are dividing it into upper respiratory tract and the lower respiratory tract. The structures from the nose till the larynx, we will consider as the lower respiratory tract. Upper respiratory tract structures from the nose till the larynx, you term it as a upper respiratory tract structures. If there is any infection or any other abnormalities of respiration which is related with the structures between the nose and the larynx, you will also give it the termination as a upper respiratory tract infections, upper respiratory tract problems. Okay. And the structures beyond the larynx until the presence of alveoli. If you encounter any abnormalities, then you will term it as a lower respiratory tract disorders. Okay. So based upon the anatomical division, we will mainly bring the respiratory system into upper respiratory tract and the lower respiratory tract. And now we have seen that bronchus is dividing into two major divisions, which is right and the left. Both sides of the lungs, after the bronchus is entering into the lungs, it is undergoing so many divisions that you will term it as a tracheobronchial divisions. Okay. So nearly this bronchus is undergoing divisions for 23 times. Okay. So from the beginning, you will call it as the trachea and it is entering into right and the left lungs. Okay. And they have given only one side of the lungs over here. And this is the primary bronchus. The division which is giving over here is the secondary bronchus. This will further divide and that you term as a tertiary bronchus, and the quaternary, like that it keeps on going on. Up to how many times? Up to 23 times it is undergoing the division. During this 23 times of division in the bronchus, 1 minute. So during the 23 times of division in the bronchus, there is a specific differentiation that you term it as the conducting system and the respiratory system. See, start from the division 0 up to the 16th division. There is no presence of if it is represented like that, it means there is alveoli. But in these regions, there is no presence of alveoli. So, there is only the presence of tracheobronchial division up to 16th division. So, it means the air is entering into those divisions and the air is coming out of those divisions. From the atmosphere, the air is entering, and then after the 16th division, from 17th division up to 23rd division only, you have the alveoli in these structures. So, these regions, you term it as conducting zone. It means it is just acting as a conducting pathway to transport the air from atmosphere into the lungs and from lungs into the atmosphere, the reversal. And these regions from 17th to the 23rd division. In the 23rd division, if you see the diameter of the bronchiole, it will be less than 1 millimeter. So up to that, it will undergo divisions. Okay, so this region where the presence of alveoli you are seeing, so this is called as the respiratory zone, where the actual exchange of oxygen and carbon dioxide is taking place. Okay, clear? So this is what is the tracheobronchial division. So now, elaborately, you can see the three-dimensional pictorial representation of the respiratory zone. So starting from the terminal bronchiole, the 16th division, you also term it as a terminal bronchiole, where the respiratory bronchiole is emerging, where the alveoli are present. Okay, so this is what is you are calling as the terminal bronchioles. And from here all over, the bronchioles is still dividing. How long it will divide? Until the diameter of the bronchiole becomes less than 1 millimeter. Okay, clear? So all over the respiratory bronchioles is surrounded by the sac-like structure, you call it as alveolar sac. Okay, so all these alveolar sac, if you take, this is the single alveoli, and this is being covered with the blood vessel where the oxygen carbon dioxide exchange is going to take place. And this alveoli is connected to another alveoli, and this is connected to another alveoli, and all together is connected with a bronchiole division. So that is called as these structures which connects all these things is called as alveolar ducts. So many alveolar ducts will join together and it forms the respiratory bronchioles. If you talk about the single alveoli, you tell it as alveolus, and all together group you call as alveolar sac. Okay, so this is how the location and the arrangement of alveoli which is present inside the lungs. And now talking about this is what is in the inside of the lungs, where the gas exchange is taking place. Okay, and outside of the lungs is made up of what type of muscle? Smooth muscle. So this is covered by the outer covering. The lungs is covered by the outer covering called as pleura. So you have two types of pleural layers. One is the visceral pleura and the other one is the parietal pleura. So you have two types of pleural layers. The visceral pleura, as the name viscera, it is close to the lungs. And the parietal pleura, it is the outer covering which is close to the inner sides of the thoracic cavity. The lung is covered by the bony protected structure, you call it as either rib cage or the thoracic cage or the thoracic cavity. Okay, so this visceral pleura is close to the inner surface of the lungs, and next to the visceral pleura you will have the parietal pleura which is close to the inner surface of the thoracic cavity. Okay, and we have seen about the intrathoracic pressure. in the venous return, which is one of the important factor in maintaining the cardiac output. That intrathoracic pressure, it is present in the intrathoracic space. The intrathoracic space is also called as the pleural space. That is the space between the visceral and parietal pleura. This is the space inside the thoracic cavity. So you also call it as, it is also called as intrathoracic space, and it is filled with the fluid called as intrathoracic fluid, and it is maintaining a pressure which is called as intrathoracic pressure. And the important role of intrathoracic pressure in the cardiovascular system is maintenance of venous return. Okay. And what is the role of this intrathoracic pressure in the respiratory system? In the cardiovascular system, it is taking part or role in the venous return. How? How it is involved in the venous return maintenance? Because of the negative pressure. This intrathoracic pressure is always remaining negative both during inspiration and expiration. This is remaining in a negative state. So it helps the blood to move from lower parts of the body to the heart. From the inferior vena cava, the venous return is being initiated and it is being helped by this intrathoracic pressure. Because of the negativity, it always exerts a suction force. So this helps the venous blood to move against the gravity from the lower parts of the body to the heart. And in case of respiratory system, what role it is taking place is, lungs is made up of smooth muscle, and it is one of the structure in the smooth muscle which is rich in the content called as elastin. Elastin is rich in the lungs. So that is the reason during inspiration and expiration, the lungs is having the ability to contract and relax. So during inspiration, what happens? Compare lungs like a balloon. So during inspiration, the air is entering inside the lungs. There is expansion in the walls of the lungs. And at the same time, when you just fill the balloon with air, the balloon will enlarge. And once when you release the mouth of the balloon, the air exits out of the balloon and the balloon will recoil back to its original position. So as the same way, once when the air is going out of the lungs, it is having the ability to go back to its original position, contracted position. But here, the lungs is also having the ability to recoil. Because it is an elastic substance which is rich in elastin, the lungs is having expansibility. It is one of the property in the muscle of the lungs. So during that process, the lungs is recoiling, but it is not collapsed. Okay, but it is not collapsed. It was able to contract and relax and perform inspiration and expiration, but it is not relaxed. How? That is due to the intrathoracic pressure. So what is this intrathoracic pressure is doing and how it is helping the lungs to perform the function is this intrathoracic pressure. That is the pressure which is present inside the lungs between the thoracic cavity and the lungs, pleural layer. So in between that, it is maintaining the pressure, and what this pressure will do is it will always have the force which pulls the lung in outwards direction, because the outer covering of the lungs is what we are talking as the intrathoracic space, intrathoracic pressure. Since this is always remaining negative, and exerting a suction force, it always makes the walls of the lungs to move outwards. Okay, so the outer walls of the lungs is always being expanded. So even though it is inspiration followed by expiration, it will compress and exits the air out of the lungs, but it will not collapse, because in the outer side of the lungs, due to the intrathoracic pressure, it is exerting an pulling effect towards the thoracic cavity. At the same time, there is a pressure which is maintained inside the lungs, which makes the lungs to come closer, which makes the lungs to recoil, but that is also not happening. That pressure is called as intrapulmonary pressure or intra-alveolar pressure. So this intra-alveolar pressure, its tendency is always to make the lungs, it pushes inwards. So one pressure is making the lungs to push inwards and the other pressure is pulling it outwards. So there are two different pressures in both the directions working inside and outside the lungs. One is the outside pressure, that is intrathoracic pressure, pulling the lungs towards the thoracic cavity. And inside you have the intrapulmonary pressure, which is pulling it inwards. But both the pressures are at same strength. There is equal force given by this both the pressures. So because of this pressure balance, this too will always maintain its strength at the equal level. So this makes the lungs to inspire and expire without over expansion or without collapsing nature. So this is how the extensibility of the lungs is maintained. So this is what you call as the compliance of the lungs. So compliance is also called as the measure of elasticity or expansibility of the lungs. So this compliance is maintained by this pressures, respiratory pressures. Okay. And now when we talk about the pleura, there is important clinical scenario that is called as pleural effusion, pneumothorax. What is meant by pleural effusion? Pleural effusion is fluid inside the pleural cavity. Already there is a fluid inside the pleural cavity. Then what is the difference? Excessive amount of fluid in the pleural cavity. So what will happen when there is excessive amount of fluid? See, this is one of the radiographic imaging which is giving you the description about the pleural effusion. See this picture. This is the structure of the lungs. But in this picture, you can see the structure of the lungs. So here, this entire part is pleura, which is filled with excessive amount of fluid. So what it is doing, it is totally collapsing. The right side of the lungs is totally collapsed. The presence of excessive amount of fluid in the pleural cavity, which makes the lungs to get collapsed. If this still goes excess, then what will happen? You can also find tracheal shift. From the midline, the trachea will also shift to the adjacent side. Okay. And in the pleural cavity, instead of fluid, if you are finding air in the pleural cavity, you will call it as pneumothorax. And the types of pneumothorax? Then closed pneumothorax, open pneumothorax, when there is a trauma to the thoracic cavity, fracture of the rib bones, then you will encounter open pneumothorax. Only there is a pressure, only there is a trauma, but it has built up the air to leak inside the pleural cavity, that you will encounter as closed pneumothorax. So in detail, all those things you will also encounter in the pathology, respiratory pathology. Okay. So this is what is two clinical conditions you will see. So this is the pictorial representation of closed and the open pneumothorax. And then now moving to the gas exchange. For the exchange of gases to take place, I think there is a stretching break. Still you want, or we will continue? Okay. So respiratory membrane. So respiratory membrane, it is the membrane which is going to be involved with the gas exchange. This gas exchange is going to take place between the alveoli and the blood capillaries. So this is what you call as the respiratory membrane. In one side you have the blood, the other side is the alveolar space. So the thickness of the respiratory membrane should be always maintained between 0.1 to 1.5 micrometers. If the thickness of the respiratory membrane increases, what will be the rate of diffusion of gases? Increases or decreases? If the thickness of the respiratory membrane increases, what is the rate of diffusion of the gases? Why? It decreases, correct. Why? It takes more time for the gas to travel towards the entire thickness. If the thickness becomes, for example, instead of 1.5, if it becomes 2.5 micrometers, there is more travel time for the gas to move from one side to the other side of the respiratory membrane. So that is one of the abnormal condition you will encounter. So the respiratory membrane, it is the membrane which is present between the alveolar and the blood capillaries. So on both sides of the respiratory membrane, you will see the capillary endothelium in one side, because one side it is having the blood vessels. Blood vessel wall is made up of endothelial cells, the capillary endothelium. On the other side, it is having the alveolar cells. The alveoli is made up of epithelial cells. So capillary endothelium and the alveolar epithelial cells on either side of this makes the respiratory membrane. In between these two membranes, it is filled with the, what is the membrane which is between two cells? Extracellular matrix. That is what we have seen yesterday. Extracellular matrix makes these two membranes, the capillary endothelium and the alveolar epithelial cells, holded together by the presence of extracellular matrix. It means it is rich with collagen, elastin, laminin, fibronectin, all those proteins. Okay, if those proteins is not there, then the blood vessel will be somewhere and the alveoli will be somewhere. There is no connection between these two cells and no exchange takes place. So that is the integrity of the extracellular membrane. Why those extracellular membrane we have studied is because of all these terminologies. Okay, clear? And now you have seen 23 divisions of tracheobronchial divisions. And then from the 17th division up to the 23rd division, you are finding the respiratory bronchioles. So those respiratory bronchioles, enormous amount of respiratory bronchioles is holded inside the closed cavity of the lungs, one small cavity. It is because of this supercoiled structure of the structure. See, the alveoli and the capillaries, all these will be supercoiled like this. So this makes the surface area to be increased so that more gas exchange takes place within the small lung cavity. Okay. So we have seen how the body surface area which is holding the large amount of alveoli inside the capillaries because of the supercoiled structural representation. And now when talking about the respiratory membrane and few clinical conditions, how it will look like, we will see. See, in case of emphysema, there is destruction in the wall of the alveoli. So when there is destruction in the alveolar wall, it means the alveolar epithelium is damaged. So in case of that, the respiratory membrane will not take part its role in the oxygen carbon dioxide exchange. And next one you will see pulmonary edema. So in pulmonary edema, am I fast? Yes or no? Okay. So in pulmonary edema, if you see, there is accumulation of fluid in between the capillary endothelium and the alveolar epithelial membranes. So it increases the thickness of the respiratory membrane, which automatically delays the rate of diffusion. Okay. So this is what is the main thing which is happening in the pulmonary edema. We are just seeing the outline of some clinical scenarios related with the respiratory membrane deviations. And in case of bronchial asthma, this is not involved with the respiratory membrane, but see here, this is the normal lungs, and see here, there is constriction in the lumen of the bronchioles. So it means the amount of air entering into the bronchiole itself is less. So in the same way, the amount of air which is going out of the lungs through the bronchioles will also be decreased. So that leads to decrease in the rate of diffusion in the gas exchange. So we are going to study in detail about the respiratory functions. But the structures, the respiratory tract structures, apart from respiratory functions, it is also involved in other functions, mainly the nose, which is having the olfactory sensation. So olfactory receptor which is present in the nose, which plays a major role in the olfaction process. And then next one is the nostril has. What is the role of the nostril has? It prevents and traps the dust particles and the foreign particles from entering into the lower respiratory tract regions. And also the sneeze reflex and the cough reflex. It is mediated by the ciliary structures which is present in the respiratory system. And yesterday we have seen a condition which is due to the mutation in the ciliary protein. Cartagenous syndrome. Yes, good. What is the triad of symptoms we will find in that case? Bronchiectasis, recurrent sinusitis, and situs inversus. So in that case, there is recurrent infection in the respiratory system because of the absence of ciliary structures. It is getting mutated. So what happens? By mistake, for example, if there is any entry of foreign particles through the nose or through the mouth, the ciliary response will make the sneeze and cough reflex to work out, and it will expel the dust particles at the level of upper respiratory tract structures itself. If the cilia is not functioning in case of Cartagenous syndrome, so what will happen? The foreign body will enter into the lower respiratory tract and it will cause its deviations. Okay. And what is this? This is the histological picture of alveoli. So alveolar epithelial structures. You have two types of cells, type 1 and type 2 alveoli. So this type 2 alveoli we will see in the forthcoming slides. Its main role is involved in the production of surfactant. And what is the role of this type 1 alveoli? The type 1 alveolar cells, they are also called as pneumocytes. The alveolar pneumocytes, type 1 pneumocytes, which is present in the alveolar epithelium. It is going to take part a role in the immune function. They are going to modify themselves as the alveolar macrophages. In case if the foreign body or any infectious substance, it is overcoming the sneeze and cough reflex, entering into the lower respiratory tract at the level of alveoli. These type 1 pneumocytes modify themselves as alveolar macrophages engulf and kill the foreign substances. So that is one of the important function of type 1 alveolar epithelial cells. Okay.